Hello and welcome to Live Healthy West Virginia, the podcast brought to you by WVU Medicine, aiming to help everyone live a better, healthier life in West Virginia and beyond. I'm your host, Mary Ravazio Menard. If you've ever had a routine colonoscopy, then you're familiar with an endoscope, the minimally invasive scope with a camera and other tools to examine your colon and digestive tract. Advanced endoscopy is used for more than just screening. It's an alternative to surgery used in diagnosis, removal of blockages, removal of precancerous cells, and much more, all without an incision. Add artificial intelligence to the mix, and we're entering a whole new era in advanced endoscopy. So today we're talking about all these exciting advancements with Dr. Shyam Thakkar, Director of Advanced Therapeutic Endoscopy at WVU Medicine. Welcome, Dr. Thakkar, to Live Healthy West Virginia.
Thank you so much for having me on the podcast. It's exciting to be here and exciting to be able to reach so many individuals through this platform. I'm excited to be a part of it. Thank you.
That's great. We're happy to have you. Yeah. So let's start first with, because some people might not really understand. What is advanced endoscopy? Yeah, well,
you did a really good job of explaining it right now in the intro. So advanced endoscopy is essentially, it's a type of endoscopy that we perform, that we get additional training on. We spend an additional year beyond our general gastroenterology fellowships to be trained in advanced therapeutic endoscopy. And essentially what this allows us to do, traditionally it's allowed us to do the procedure known as ERCP, which is a procedure where we inject contrast into the bile duct and the pancreas duct. The bile duct is the duct that drains the liver and the gallbladder.
Okay.
We use it to treat ailments of the bile duct. Sometimes patients develop common bile duct stones, can develop infections in there, develop pancreatitis. We can reduce those obstructions by removing the stones or placing stents or treating various types of small tumors in that area as well. Additionally, what advanced endoscopy has grown into over time, over the last few decades, is to involve endoscopic ultrasound. That's much like the scope you described with the light at the tip, except now we have an ultrasound transducer at the tip. And this allows us to see organs around the luminal GI tract. So organs outside of the stomach, organs outside of the small intestines, the esophagus, the chest, and the rectum. And so whenever we're doing these types of procedures, we get a full visualization of the pancreas. If there's a lesion on the pancreas that's been growing or a cyst that's seen on cross-sectional imaging, we can now biopsy through the stomach wall or small intestines wall using endoscopic ultrasound.
No surgery for that.
No surgery again for that. And now what's really happened is the technology has really grown exponentially over the last decade. And so with endoscopic ultrasound, we can now do a lot of therapeutic procedures. What I just described to you with the biopsying and visualizing is the staging and diagnostic work. But now with the therapeutic procedures, we have certain types of devices available to us now, like what we call lumen-opposing metal stents, where essentially with endoscopic ultrasound, we can see that there's an area of infection or an area of a collection that's formed from an episode of pancreatitis. Or there's an area of small intestines that we can access because the stomach is blocked from a tumor. We can then, with this lumen-opposing metal stent under endoscopic ultrasound guidance, essentially visualize those areas and create a tract between the area of the stomach and the small intestines, or that cavity or that infection, and drain it internally or bypass the obstruction, whatever it might be. And so these are different types of therapeutic endoscopy procedures, but in essence, it's really the practice of endoscopy in a way to not just perform diagnostics and screenings, but actually to perform therapeutics like removing early tumors or bypassing areas of obstruction or draining areas of infection. And so I think, it's really come a long way over the last, 20 years essentially. And it's funny, it took the first endoscopy was performed by Basil Hershowitz in the 1950s, and it took a long time for endoscopy to become mainstream. But since then, it wasn't until the mid 1980s that endoscopy was mainstream. And it was a long time to get to that point. But since then, we've come very far with endoscopy in a short interval time to essentially create this age of exponential endoscopy, which is to really find different ways and better ways to optimize patient care in a minimally invasive fashion, like you described.
More of a standard of care.
Yes,
and
absolutely.
It's all minimally invasive.
It's all through the mouth or from down below from the rectum, yes, without an incision. So we work very closely with our surgeons, though. I mean, our surgeons are our team, and I think it's really important to work closely with them so that you understand kind of what's in the best interest of the patient, and we individualize the care, especially in pancreatic disease because it can be so complex.
So let's talk a little bit about what are the most common conditions and illnesses that you treat through advanced therapeutic endoscopy?
Yeah, so some of the things that we treat include pancreatitis, pancreatic cancer, we treat common bile duct stones, we treat early tumors of the GI tract. So early tumors in the esophagus or in the stomach or in the rectum or anywhere in the colon or in the small intestines. We can remove them endoscopically and essentially get a histologic cure of that tumor when they're early. When they're more advanced, we can stage them, perhaps even do some localized treatments to them with cryoablation. So that's a spray of liquid nitrogen to freeze the disease. And by freezing and rapidly thawing, it allows the cells to shrink, and it can oftentimes control the area of disease. We oftentimes can do that in patients who have esophageal cancer. And then we can place the stents to bypass, like I described, or stents to open up the lumen as well. So, these are the various most common things we do. But I'd say probably the big ones are the common bile duct stones, the pancreatitis, and treating of the Barrett's esophagus, which can predispose patients to esophageal cancer as well.
You cover a lot of ground with one tool.
Yes.
So let's talk about some of these conditions. You mentioned that one of the conditions you treat is pancreatitis. What is pancreatitis, and how do you use the endoscope to treat pancreatitis?
Yeah, great question. So pancreatitis is inflammation of the pancreas to cause belly pain, nausea, and vomiting. It generally occurs as a result of a condition. So perhaps a common bile duct stone got stuck as it was trying to come out of the gallbladder into the bile duct and kind of put pressure on the pancreas duct as it was trying to come into the small intestines. This can lead to pancreatitis. Other conditions that are commonly cause pancreatitis include alcohol. Other conditions that can cause it include various underlying metabolic disorders such as hypertriglyceridemia. Patients can have abnormal ductal anatomy of the pancreas known as pancreas divisum. There's multiple things, including medications that can cause pancreatitis, but it's that inflammation of the pancreas that can cause belly pain, nausea, and vomiting that really is pancreatitis. Generally, it's mild, and it can be treated conservatively. The vast majority of cases are mild and treated conservatively. However, it is still the #1 cause of GI admissions in the United States. So it is quite common, okay? Wow. That being said, when patients develop pancreatitis, though the majority are mild, some can be severe and can develop what we call necrotizing pancreatitis, which is when they develop that severe pancreatitis, they can also have such severe injury to the pancreas from that inflammation of the insult of that stone or the alcohol or the hypertriglyceridemia that it's irreversible, and some of that tissue necroses and it can die, unfortunately. Yeah. But, the body tends to try and reabsorb that. Oftentimes, though, because of that necrosis happening, that area can get infected and it can threaten the patient's life. And so what we can do is endoscopically go in, assess the area, perform a procedure where we drain that infection internally or that necrosis internally, or at least allow us to gain access to that necrosis, after which point then we can use our normal or I shouldn't say normal, but our routine endoscopes, our upper endoscope, to actually go into the cavity and clear out the necrotic debris so that things come back to normal and the patient recovers well.
And
that's
I imagine
one way
it's a less painful and it's faster recovery after something like that, as opposed to open surgery.
Yes. So whenever we treat these, we do this in a multidisciplinary approach. We speak to our surgeons, we speak to our radiologists, we speak to our interventional radiologists, all to make sure what kind of is the best approach in the patient. In the past, surgical approach was the most common thing for patients with walled off necrosis of the pancreas. However, that carried what we call a very high morbidity, which is complication rate. Patients would develop, all types of what we call fistulas, which were drainage tracts from the collections or from the pancreas to the skin. They could develop infections, wound infections. There was even a risk of death with that, However, that being said, we now have our endoscopic approach, which is much more minimally invasive, much less pressure on the patient, and much preferred as the appropriate approach when the collections are in close proximity to the luminal GI tract. So like in close proximity to the stomach or to the small intestines, it allows us then to be able to safely and effectively drain these cavities internally and clear out that infection. We can also place, small caliber feeding tubes to kind of get them through the acute episode. And then once the acute episode is resolved, we remove those feeding tubes and patients do really well. And so it's really evolved as the first line therapy or the goal therapy of these patients. Now, sometimes the collections are in positions where it's not good for an endoscopic approach, in which case we'll turn to, the IR colleagues may weigh in or help in terms of improving that outcome, or the surgeons may have to go in and debride an area. But again, we're very kind of cognitive about all of this so that we try and put the patient at the least risk with the best outcome,
What about pancreatic cancer? I mean, this is a pretty aggressive form of cancer. How do you treat pancreatic cancer endoscopically?
So pancreatic cancer is one of the leading causes of cancer-related deaths in the United States. As you know, it's a third leading cause of cancer-related deaths in the United States. Approximately 54,000 people are diagnosed with it annually, and approximately 52,000 people die of it annually, okay? That being said, we've seen the survival rate increase year over year, which is great. And that has a lot to do with our advocacy groups, places like the National Pancreas Foundation, Pancreas Cancer Action Network, and of course our health system, like WVU Medicine. And so, a lot is being done to try and improve the outcomes related to that. When it comes to pancreatic cancer, some of the things that we do endoscopically to help treat this is first making a diagnosis, right? I mean, one of the challenges with diagnosing pancreatic cancer early is that pancreatic cancer oftentimes doesn't present until patients are very advanced in the disease, okay? Patients may have symptoms of abdominal pain, nausea, but these are common symptoms that you could, chalk up to an infection in the stomach, an ulcer, So it's hard to diagnose early sometimes, but with endoscopic ultrasound, we're able to really well visualize the pancreas, especially in a high-risk patient. We can even do screening of those patients to see if there's anything abnormal. We find an abnormality, and we can potentially knock it out before it turns into a cancer, So that's one way. Another way is when something is seen on imaging, we again do the endoscopic ultrasound and very quickly make that diagnosis. We now have some tools that are FDA approved as well to perform radiofrequency ablation of certain types of tumors in the pancreas using endoscopic ultrasound through a little needle. And so, we are looking at that in patients with certain types of pancreatic cancer to see if it will be beneficial in those that are not good surgical candidates, okay? And then other ways are, we know that cysts certain types of cysts can be precursors to the development of pancreatic cancer. There was a patient that I saw, that I just reviewed in our pancreas conference before coming here today, which was, he was treated previously at the Mayo Clinic for his cyst, and then he had come and he had recurrence of it. And they thought it was more of a benign type cyst initially, but what has now occurred is a pre-cancerous type cyst.
Okay.
But what we were able to do was, once we made that diagnosis, we actually injected that cyst with a special type of therapeutic chemotherapy regimen, gemcitabine and paclitaxel. And essentially, his most recent imaging shows complete eradication of the cyst.
That's wonderful.
Which is great news for him, right?
Yeah.
That risk of pancreatic cancer certainly dropped to much lower than it was previously. We don't have good long-term follow-up on these patients to know exactly what it's going to be because it is a new treatment.
Sure.
But we feel very good in the sense that he had a 5-centimeter lesion. Now it's gone. That's very exciting.
And gives you hope.
Yes.
Gives you hope.
Yeah.
What about more common like GI tract ailments? Would you use advanced endoscopy to treat like reflux or, I know you mentioned Barrett's esophagus, or is it for more complicated GI disorders?
No, so that's one of the things that's really, really impressive about advanced endoscopy is we can use it in various ways, and our training has allowed us access to devices that haven't been available in a general GI type of training. And so as an example, you talk about reflux. Patients with gastroesophageal reflux disease may benefit from certain types of endoscopic procedures that we have out there now. One of them is called essentially a procedure where we do a endoscopic mucosal resection of the GE junction to tighten that lower esophageal sphincter and prevent reflux from happening. Okay, it's a very new procedure, but we're seeing really good results with it. Another is the TIF procedure, transoral incisionless fundoplication, where again, we have access to a device to essentially create a 270-degree wrap at the lower esophageal sphincter between the esophagus and stomach to prevent reflux from happening. So if you're familiar with the surgical therapies for reflux, Nissen fundoplication is the most common one. It's been around for like 50 years.
What is that?
And that's basically where they wrap the lower esophageal sphincter with the stomach by creating a 360-degree wrap to tighten that area.
Oh, okay.
Now, when that happens, patients do well with the reflux component, but still sometimes patients can develop various other types of side effects, gas, bloat, or the wraps can get undone, or they can develop difficulties with belching and things like that, or difficulties with bloating and things like this. And so, one of the things that this type of TIF allows us to do, the first generation wasn't great because the fasteners weren't strong, but the fasteners have come a long way in the second generation. It can help prevent reflux. And we don't see those same side effects that we saw with the Nissen fundoplication because it's only a 270-degree wrap. So we get a lot of the benefits of the reflux control without the side effects that we saw with the full 360-degree wrap. So it's a great procedure. It works very well for patients with reflux. The downside is it's a bit limited in the sense of who we can do. Patients with hiatal hernias present, when part of the stomach is above the diaphragm, that's what we call hiatal hernia. Then that becomes difficult to do a TIF procedure on because you can't really tighten that junction below the diaphragm. So, but it's exciting to have that available for those without hiatal hernia. Talked about Barrett's esophagus, changing the lining of the esophagus that predisposes patients to the development of esophageal cancer. It increases their risk about 30 times that of the general population. For that reason, we continue to surveillance patients with Barrett's esophagus. But despite our surveillance every 1 to 3 years, we've never been able to slow the incidence of esophageal cancer. In fact, it continues to be on the rise, We now have treatments over the last 2 decades, radiofrequency ablation, the cryoablation, and endoscopic mucosal resection, which essentially allow us to treat that area of Barrett's and completely eradicate it.
Wow.
Yeah. and completely eradicate the precancerous cells there. And it's been shown in the biopsies that we do after we do these treatments that the esophageal epithelium, like the surface of the esophagus, is genetically healthier than the pre-existing surface that was there. And so what all that means is that that risk suddenly goes down tremendously.
Yeah.
And we're talking about complete eradication rates of 90 to 95%, depending on the study you read, 80 to 100%, depending on the study you read. So this has really evolved as the mainstay for patients with Barrett's. Back in
a lot of different ways to treat cancer.
And 20 years ago, it was esophagectomy, which was to remove the esophagus, which is a very involved procedure. Now we don't do that for patients with dysplastic Barrett's epithelium with precancerous findings. So, it's a lot's come by. We still don't do that treatment for every single patient with Barrett's. We reserve it for those that we find any type of precancerous cells. But it's really great to see that. Yeah.
That's exciting.
Yeah.
That's exciting. Yeah. It's like the Swiss Army knife of,
That's
procedures. It's just, what doesn't this thing do?
Yeah.
Well, and you mentioned a little bit earlier that you can access organs outside the GI tract.
That's right.
So you can, what was it? Cirrhosis. You can treat conditions like cirrhosis of the liver. You can remove gallstones.
Yeah. So great comment there. So the FDA recently approved that lumen-opposing metal stent, not only for treatment of these collections around the pancreas, but now for drainage of the gallbladder. So in a patient who has cirrhosis of the liver that may not be a good surgical candidate, that has an inflamed gallbladder, we can go in and endoscopically basically deploy that lumen-opposing metal stent from the small intestines, the duodenum, into the gallbladder and evacuate the infection or the inflammation of that gallbladder, and at the same time evacuate the stones from the gallbladder. So we're able to do more and more with these types of technologies, which is really great. I love your Swiss Army knife analogy. I think it's perfect when it comes to advanced endoscopy. Certainly it's not perfect. Some of these procedures are challenging, and we're talking about entering spaces that are free spaces. They're not luminal spaces. So they're spaces that they're spaces that the endoscope has not previously been designed for. So now you have a new set of challenges that comes up. But I think you always have to just be cognizant, like, is what we're doing in the best interest of the patient? And as long as it is, then I think you're always doing the right thing. And you keep that at the forefront and then kind of move forward. So to answer your question, yes, we can treat these things, but it always comes with a little bit of a grain of salt that we have to be cognizant of what our limitations are and want to make sure that we're doing what's in the best interest of the patient.
Well, speaking of improvements, we hear a lot about artificial intelligence on all kinds of platforms these days. How is artificial intelligence, how's AI changing or improving advanced endoscopy?
Yeah, so that's great. So artificial intelligence basically is the use of essentially computer vision or machine learning to help us better our outcomes with endoscopy. And when it comes to artificial intelligence in endoscopy, we've really seen the GI space in general be a space where there's a lot of opportunity for AI. Whenever we're doing screening colonoscopy as an example, we've all understand that screening colonoscopy is the gold standard for colorectal cancer screening. It's the only test where you can screen, diagnose, and treat all at once. One shot.
Swoop,
But that being said, there's still lesions that could potentially be missed. Endoscopists suffer from fatigue, variability, difference in standardizations. Patients' preparations can alter courses, or the colonic tortuosity can certainly make it difficult sometimes to find polyps, and it's devastating should any patient ever develop a colon cancer after having a colonoscopy. So one of the things that artificial intelligence really helps us with, which we have here at WVU here at Ruby Hospital, is the GI Genius, which is essentially an opportunity to highlight polyps as we're performing the colonoscopy exam. So the data has shown us that it increases your polyp detection rates anywhere, or your adenoma detection rates, which are the precancerous polyps, anywhere from 10 to 15%, depending upon the study you look at there again as well. And so that's a great innovation, I think, in endoscopy that we've seen, is the use of artificial intelligence to help us ensure that we're getting the highest possible quality exam for the patient.
You're seeing more.
Yes, exactly. Recognizing more.
Another set of eyes.
It's another set of eyes, which I think is always important. And so with that, artificial intelligence isn't just stopping at colonoscopy. We're seeing it being developed for endoscopic ultrasound. We're seeing it being developed for ERCP procedures. We're seeing it developed for our dictation, our report creation, so that there's no errors in the reports. And I think all of this is great because it allows us to harness the technology and make it the best possible use of it for the purpose of the patient, and so these are the different ways we're seeing artificial intelligence really come mainstream, and the FDA has already approved 2 systems in endoscopy for that.
Wow. Yeah. So there's going to be more improvements.
More coming. Yes.
Excellent. Okay. So this is also a good option for, you mentioned a little bit earlier about, if you're a critically ill patient and you just can't withstand regular surgery, maybe there's an endoscopic, boy, I'm on this today, an endoscopic procedure that
That's right.
can help you treat these patients that just can't withstand major surgery.
That's right. So, common conditions where we may have that discussion with our surgical counterparts, or like we described, a patient with cirrhosis with an inflamed gallbladder, a patient with an obstruction of the luminal tract after previously being operated on, a patient with, unfortunately, with recurrent cancer with an obstruction, where any type of operation would be much more challenging, and put the patient at a significant risk. A patient with, where the outcomes of the surgery may be more higher risk as compared to the endoscopic approach. And so those are different ways in which, like the drainage of the walled-off necrosis, or the benign cyst from pancreatitis that can form. So these are ways in which we would use endoscopy as an alternate, or even as the first line, when we have a situation between endoscopy and surgery and what's in the best interest of the patient.
Okay.
Yeah.
Well, I know you've been doing this for a while. Can you talk a little bit about the expertise of the team of the WVU Medicine Advanced Therapeutic Endoscopy team? Endoscopy.
That's a good question. That's a great point. So, we wouldn't be who we are over at Ruby Hospital and here in West Virginia if it wasn't for a great team. I mean, I think, our mission, our goal has been to always take a team approach, because I think, when we work as a team, we achieve more for our patient outcomes than if we worked individually. And so we have a fantastic, leader in bariatric endoscopy and also a therapeutic endoscopist in Dr. Shailendra Singh. When I say bariatric endoscopy, he does a lot of the endoscopic weight loss procedures, specifically endoscopic sleeve gastroplasty, or he does TORI, patients who may have had a Roux-en-Y gastric bypass, but their pouch has increased in size. He's able to reduce them down. He's also able to manage a lot of the complications that occur from bariatric surgery, and those that unfortunately may have been in that small percentage of patients that the surgery went well, but they had a complication that needs to be treated. He's able to treat those complications. He's undergone specialized training, even beyond just therapeutic endoscopy, but specifically in bariatric endoscopy. And so he's outstanding at that. And, he's in his patient population with the bariatric endoscopy procedures, we've seen great excess weight loss, up to 19 to 20% in that cohort, as well as great outcomes in terms of how they're doing and their quality of life. And so he's been really instrumental to building the program, and of course all the team around him when it comes to bariatrics. The nutritionists, the nurse practitioners, the nurse coordinators, the whole team really goes into effect to help with that. Another one of our partners, Matthew Skip Kraft, he joined us after doing his advanced endoscopy fellowship in Minnesota, but prior to that he was actually trained here at WVU, and so he's been fantastic as well. He's another advanced therapeutic endoscopist who does all these procedures that we described already outside of the bariatric ones, but also helps us with various types of nutritional treatments through advanced endoscopy. So specifically direct jejunal feeding tubes, or what we call percutaneous endoscopic gastrostomy with a J tube extension. These are various ways to create nutritional opportunities for patients that might have obstructions or might have ailments like gastroparesis that can be optimized. He's also really leading our therapeutic work around gastroparesis. When the stomach doesn't empty properly, patients get very sick with constant nausea and vomiting, or chronic nausea and vomiting, I should say. And so he does a procedure known as a G-POEM, where essentially he creates a tunnel in the stomach wall and is able to divide the circular muscle fibers of the outlet of the stomach called the pylorus. And this allows the food to empty out of the stomach much more easily.
And takes care of the nausea.
And takes care of the nausea. And patients do really well with that, We're still looking at the really long-term outcomes with that, but at least at 6 months, we're seeing really good outcomes with that. So, these are two of my colleagues. We're growing the team. Dr. Yusuf Hadi will be joining us. He's a advanced endoscopist being trained currently at Mount Sinai in New York, and he'll be joining the Martinsburg campus. And we're excited to have him on board. He actually trained with us as well in residency and fellowship, but went to Mount Sinai for advanced training, and then will be joining at Martinsburg. And we're excited for him to help us serve that population, because as you know, with the panhandles, sometimes access for patients becomes a challenge to come here to Ruby Memorial or Morgantown, but having an extension there is going to be really great. And then we're starting a program in Wheeling as well, and so that just started last week, and we're excited about the ability we've been able to do to help serve those patients as well. So I think all in all, all this happens though with great nursing support, great nurse practitioners who help us extend. And I always say, if you see our room from a bird's eye view, the room is not built around me, and it's not built around the patient. It's built around the nurse, because she has access, or he has access, to the patient, to me, to the devices, to the equipment, to the anesthesia team, access to every person in the room, every piece of the room. So as good as that individual is, and we've been really blessed with having a great team here of nurses that can do that work for us. Yeah.
Okay, so before we go, I've got to ask you, what is the most important thing you want our viewers or listeners to know about advanced therapeutic endoscopy?
Yeah, I think probably the most important thing I would say just in general is to know that there's always options, and not to give up any type of hope, or not to think that, there's a finality to things, but rather, look at it as, there's always an option out there with different types of treatments. Yes, there may be some risks that are higher when you have really advanced disease, and it may not be worth it, or it may not be the right thing to do in that scenario. But there's also, it's also very important for that patient to be educated and to know that. So making an informed decision as to anything only happens after you explore all your options.
Right.
And I think, if there's ever a GI ailment and advanced endoscopy hasn't been part of the conversation, as a potential option, it's worthwhile to ask your physician, hey, is there anything from an advanced endoscopy standpoint that could be done here?
There probably
to
is.
Help. and there's a good chance there it could. It may or may not be, but there's a good chance it could. Right now we still live in an underserved state where there's the access becomes a little bit of a challenge. But I think more and more we're growing, and so like we talked about with Martinsburg and Wheeling, and there are providers in Charleston as well. We're excited to see that opportunity continue to grow. So I think it's important to always talk to your provider and see how we can get to the closest individual possible to give an opinion at the minimum and go from there. And then you can make an informed decision,
Okay, great.
Yeah.
Well, thank you so much. Boy, we covered a lot of ground.
Yes, we did. I hope I didn't-
That's great.
hope I
That's
didn't
great. Good information. Thank you for being here. It was great having
Thank
you.
you again for having me. It was very exciting, and look forward to hearing what the upcoming podcasts are as well.
All right, great. Thank you.
Right.
Well, that brings us to the end of this edition of Live Healthy West Virginia. If you're looking for more information about advanced endoscopy, you can always visit wvumedicine.org/advancedendo. And to find the latest episode and all of our episodes of Live Healthy West Virginia, visit wvmetronews.com/podcast. I'm Mary Ravazio Menard, and on behalf of Dr. Thakkar and everyone at WVU Medicine, thanks for joining us.